Good afternoon, everyone. So it's my pleasure to talk about some of the initial results from Study 2, the biggest study. If you exclude Study 1, which is really just gathering demographic information about the populations and about the patients in your practices, then Study 2 is really our largest study, and I think we did pretty well, 90% of our goal. I think there's not been anything like this, and I think I could go on about the values of practice-based research. I hope it just gets bigger and bigger. But I'm going to talk only about a piece of the overall Study 2, which had a lot of objectives, which I'll review today, the effect of medications on saliva and some of the early results. And actually, this is an excerpt of a poster that Lloyd Mansell has prepared with the team, and he is presenting that at the IDR meeting in a couple weeks. So what you see here is really pieces of that, but I think it serves as some of the highlights of what the findings are to date from the study. We have 4 posters at the IDR from Study 2, and this is only based on the data to date, where I think we'll see a large number of publications. And I think this is the kind of information that will impact the public. We were discussing yesterday about what do your patients want to know about big changes in dentistry, and this is the kind of study that will give us some of those big changes. So I hope to kind of paint that picture in the next few minutes today. Let's go back in time, and let's talk about why we did this. You remember this list from how many years ago did we do this? 5 years ago? Something like that? We asked you, the practitioners, what was of interest, what are the questions that you have in your practice, what is important to you. And actually, cracked teeth was number 1, right? That was the most interesting thing, but I think statistically those top few are all about the same. And indeed, those 2 separate items related to caries, healthcare strategies, salivary diagnostics, were prominent on your minds. And I've seen myself, in talking to practitioners and in the lectures I do on caries, an incredible growth in the interest amongst practitioners in managing caries as a disease. And I think this salivary study is a first step towards that. So let's talk about why this is important. I'm going to take the liberty, since the results here are just a few bullet points, but big, just a few take-home big points. I don't need to spend a lot of time on the results, and I think since we have our expert, Dr. Smith, the pharmacologist, he can explain for me perhaps why we got the results that we did, although I think it will be somewhat self-explanatory. But I want to go back in time and explain why this study is so important. You picked it, you said it was something of interest to you, but I want to give you my take on the importance of caries management studies. So if you go back in time, in 1882, in the same year that Robert Koch developed his postulates which were the seed for modern microbiology, the first sort of dental microbiologist, Miller, gave this definition of dental caries. So if you read the definition, and I'm not going to read the whole thing, he talked about that it's a chemical parasitic process, there's dissolution of enamel mediated through bacterial acid production. Now, if I looked up a definition today for caries, I might write that same one. So, in other words, for 130 years, we have known that caries, this most prevalent disease in humans, is a disease that occurs over time, that it starts out in a very incipient manner, it gradually develops, and then suddenly the patient shows up in your office with a hole in their tooth, and that's when it's first presented, that's when we first deal with it. But we don't treat the disease for the most part. So that's an important point to remember. So the basis for the salivary study was you thinking about, well, there's a disease here, how do I assess the risk of the disease, and how do I treat the disease rather than wait for the hole to form in the tooth. Even G.V. Black, the guy who we credit with all the cavity classifications, if you read his stuff, he talks about prevention and the fact that he regretted the fact that he was compelled to restore the teeth and wishes that this could have all been prevented. So this is nothing new, but I think we're merging into an era where things are changing. You may have heard me show this before, but I think it's just fascinating to kind of give the flavor of why this salivary study is so important. This is in 2006, I get this magazine called Science News. It gives you the weekly update on what's new in science across the board, from astronomy to anthropology to physics, whatever. This summarizes the published science of the week. And at the end of the year, they publish the most significant science of the year, okay? What impacted the world scientifically the most? So I was looking at this thing 5 years ago, and I saw there's a tooth in there. You may have seen me show this before, and I thought, what could be important about a tooth in 2006? And then if you look at it, it says that they discovered in Pakistan the oldest examples of dental work, drilled holes and fillings dating back 9,000 years. And I said to myself, isn't that what we do today? Has anything changed in 9,000 years? You know, we wait for a hole to form, we clean it out, and we fill it up, right? I mean, we have nicer ways of doing it, but that's essentially what we do. Yet the disease that led to that hole was not treated, the most prevalent disease in humans. So what you were asking for when you said, let's do a salivary study, is how can I assess the risk of a patient to get this disease, and then perhaps I can deal with it differently if I know they're at higher risk. That's really what the whole premise of Study 2 is about, all the different aspects of it. And indeed, the focus of dentistry has shifted from historically treating the result of dental disease, that's most restorative dentistry, to preventing disease. And I think water fluoridation being an example, it was cited as one of the 10 most cost-effective public health measures of the 20th century. So we've been leaders in preventive dentistry. But I think the era that this study says we're getting into is reducing risk factors, not treating everybody the same, but identifying which segment of the patients that we see is at greatest risk, and how do we treat them differently as a result of that risk, and then how do we not ignore the others, but perhaps not pay the same kind of attention to the low-risk patients as the high-risk patients. I mean, medicine has done this somewhat. We have not done this in dentistry. So the idea of the salivary test is maybe there's something there that tells us, within the scope of these salivary studies, that a patient is at higher risk. So why is this important? It's important to keep our eye on how big this is financially. So the world of dentistry, the world we live in, is about a $100 billion business. That's the gross domestic product of dentistry in the United States, which is about 40% of the world's dental market of about $250 billion a year. So Americans are spending $100 billion a year on dentistry. That's a lot of money. 80% of that is professional fees, 8% professional products, and 12% consumer products. Okay, so if you look at that $100 billion differently and you say, what is the reason for the expenditure? Why did we spend $100 billion a year? And then you can see that 60% or $60 billion a year in the United States alone is spent on the results of dental caries. So what are the results of dental caries? Most restorative dentistry, most prosthodontics, most endodontics. So we're spending $60 billion a year on cavities. Okay, now if you compare this, you can go and look up, you can Google the most expensive diseases, and heart disease is number one. I think it's $225 billion now, and they expect it to go up dramatically. And then there are other diseases that are way up on that list. Gastrointestinal disorders are about $70 billion a year. Cavities is $60 billion. So cavities in the United States is almost the same size as all gastrointestinal disorders. It's a big disease. It's a very expensive disease. Yet we're not treating the disease at all, for the most part. We're waiting for the holes to form in the tooth, and then we're drilling and filling. So my point is, we're doing surgery, we're not doing medicine to prevent it. And that's why it's important. I ask audiences all the time, about lay audiences, because I'm a pediatric dentist, and I show them this picture, and they look at this, people who are not in the dental profession, and they compare notes about how many cavities they have, and they think about a cavity as a nuisance. It was just something I had to go to the dentist, maybe I had an injection. It wasn't a big deal, it didn't change my life very much, so why even bother worrying about cavities? Why are we even talking about this? Well, for the child it might not be, but then I show them this picture. And this is a child in Seattle, Washington, that you could go to any affluent part of the world. You could show adults the same way. This is a 2.5-year-old child with 20 teeth with severe early childhood caries, which is on the increase, by the way. That's the only group of patients where caries is on the increase is preschoolers, and it's dramatically going up for a variety of reasons that I won't get into today. But my point is, this is kind of a take-home of why we need to look at risk factors. This 2.5-year-old, when they were age 1, probably went to their physician, probably already had several well-baby checkups, and at age 1, for that well-baby checkup for the immunizations, they probably had about 6 teeth, and those teeth looked fine. Those teeth looked perfect a year and a half earlier. So it's a perfect example of risk assessment in that little capsule of the kids' world, because 85% of kids in Seattle go to the pediatrician and get all their immunizations by age 3. They've gone to all those well baby checkups. But less than 5% have had a dental checkup. So we're not going to change. We have to figure out how to collaborate to work on risk assessment and focus on these kids before we see that, and adults. And every week in the emergency room, we see 2 or 3 kids walking in the ED like this with life-threatening infections. This should not happen in 2011. This kid looked great at age 1. His teeth looked perfect. But he had a risk, and we just didn't know what it was. So saliva, there may be something there in saliva. And I think our study is going to be one of the... We didn't examine those young kids. Okay, we looked at older kids. But I think as an example, this kind of highlights the importance of trying to identify the risk factors. Here's a patient, you may have seen me show some of this before, who had these beautiful, I think those are called cast posts and core, is that right? I'm a pediatric dentist, I don't do that stuff anymore. And you look at that and it looks okay, then you look from the facial and those beautiful restorations are destroyed from some kind of rapidly progressive caries. So I suspect that saliva was a major issue in this case, okay? So if you have that looks like a patient who had salivary deprivation in a severe form. Our study intended to look at the less severe form. So dentistry right now lives in this world, in this upper right quadrant. If you look at caries as a time-dependent disease, even though the public doesn't think about it that way, they think about the binary nature of it. You tell them if they have cavities. That's the public's perception. They go to you, and we say, you have X number of cavities. They don't think about it as a continuum over time. So we live in this world up here, when in reality, we should be living down here, where before the structural changes are not reversible. So that's another reason for what we're doing. So what are the aims of this overall study too? And then we'll drill down to the medication part, the piece that Lloyd and team talk about in much more detail in his poster, which I hope you'll go look at all the posters, but you can get a lot more detail about this from Lloyd's out there. So the first aim was to develop a caries risk assessment tool, as I just described the reason for, to predict 2-year caries incidence, the increment of caries over a couple of years, okay? That was the first aim of the study. I won't go into the specific objectives. The second aim was to determine the feasibility of a risk assessment tool in the practice setting in terms of ease of use, so we wanted to know if it's going to work in the flow. That's critically important, and I could go on about that, but I learned when we were first proposing our practice-based research network, we looked at other existing networks in the medical field, and one of the ones we looked at was the PROS, Pediatric Research and Office Settings, in the medical and pediatrician world, and most of the periodicity tables for immunizations were developed through that network. They didn't test the efficacy of the vaccinations. That was done in randomized controlled trials, mainly sponsored by pharmaceutical companies. What they tested was perhaps even more important is, I can show you a drug's effective, but if it doesn't fit into the scheme and flow of your practice, if it takes too long, or if the staff can't do it, all those logistical things that are critically important to make a good idea a reality, those have to be tested, and that's one of the more important things that we test in this network. So you will help us out a lot when we analyze that information, your perception of the use of these tests and how can we make them faster, or how can we make it better. If it has more meaning, you're more willing to do it, those kinds of things. That was a specific objective. And of course, the one I'm focusing on today is the effect of the so-called anti-sialogog, or the salivary deprivation medications, on the saliva, and then ultimately on caries experience. I'm talking just about the saliva part today. Ultimately, we want to look at that saliva as sort of a surrogate then for the caries experience that the patient would have. So the protocol, I think all of you know it. We randomly selected patients to participate. You started on a certain date. We just finished the enrollment. When did we stop? 2 weeks ago? I think it was about a week ago. I think end of February. Okay, yeah, so it was last Monday. We just finished the last few patients, right? So we have like almost 1,800 patients in the 3 age groups. And you had a random method, and I think we talked about, we altered that slightly, but it still comply with the protocol. The development of the forms, this was I remember the arduous process of creating this study with all of the staff and team was an incredible amount of work. The amount of work that led into how to design these forms, working with Axio, working with Brian and his team was, just get that all set up was enormous. So there's a tremendous amount of work that led to the capture of data in those 1,800 people. you asked a lot of questions of the patients. Your staff person did the salivary test. You did the examination. It was blinded to you, so you didn't know, although you could actually see the saliva, you didn't know some of the specifics of the salivary testing. And then you did this medication history, okay? And this was challenging, and we'll hear later on at other times how we could improve upon this. But this is really important. We gathered information about what medications, frequency, duration, was it OTC or prescription, et cetera, okay? And then your staff person did the salivary test. You did 6 different tests. I'm not going to go through all of them, but we did a pre-study. Marilyn and team presented previously on the reliability of these tests and the fact that they could be used with ease and the reliability. We actually discovered some initial problems with the ability to detect the color, and especially in the buffering capacity test. We made some alterations in that regard. So there was a lot of work that led into the development of this study. So at the end of the day, there were about 30 patients per practice. 56 of your practices were involved. The data that I'm reporting here included 1,500 subjects, but there now have been almost 1,800 subjects. And they range in age from 9 to 97 years old. Obviously, a lot of different kinds of people. And I'm not going to divide out the subset of ages. The poster goes into some more detail. When we finally publish this, there'll be even more detail. Okay, I kind of clustered it just to give you the main take-home. There's way too much to talk about in terms of data already, and this is just one part of Study 2, this effect on medications. So in looking at the types of medications that the patients were taking, first, again, you have to kind of think about how you're going to cluster this, and there was a lot of work by Lloyd and colleagues looking at how do you cluster these medications into categories, antihypertensive, et cetera, and there's different, some people take a drug for one thing. How do you know what they're taking it for? So we had to make a determination, because sometimes a drug is used for several different things. So we had to figure out a way to cluster it, and I won't get into that methodology right now. But so this is the kind of prevalence of use of different drugs. And then on the bottom, this shows how many drugs folks were taking, how many different drugs that have anti-sialagogue potential. So these are drugs which have been reported to have an effect on saliva. So the whole premise of the study being that we know that severe salivary deprivation has a significant effect on caries. What about this perhaps subtle effects or less significant, less obvious effects of anti-sialagogue drugs? So half the patients, approximately, were taking no drugs. Okay, half the patients were taking no drugs, and that differed by age, obviously, significantly. The older, the more drugs. And approximately 8% were taking more than 3 drugs. 3 drugs which have anti-sialagogue effects. A lot of data here. That's why you got to go see Lloyd's poster. And you have this in the handout as well. So on each of these, on the top you see the different salivary tests, the flow rate, resting and stimulated, the pH, resting and stimulated, then the buffering capacity, right? Those 5 tests. And the one that's not on there is the salivary consistency. That's the viscosity of the saliva. And then on the left, you see the different classes of drugs. And then what you see in each column are the odds ratios and the range. And the bolded ones are statistically significant. So there aren't a lot of these that have statistical significance, but if I just pick a couple here, if the patient was taking some, in the cluster of narcotics, then there was a pretty high odds ratio that was statistically significant that it would reduce their resting pH. Okay, odds ratio of 4.3. That's pretty meaningful. Why that particular one? Why resting pH? I guess if our pharmacologist has time, he could explain that. Or we're going to have to figure a lot of things out. There's a lot of explanation that we're going to have to work on as we gather the tremendous amount of data that comes out of this study. So I just picked that as an example. This is really interesting, this one here. It's not surprising, but it's kind of shocking how dramatic it is, okay? And this kind of clusters everything together into the number of anti-sialagogue medications that a patient is taking, right? Regardless of class of drug. And it says that, again, the bolded is significant and the non-bolded is not, right? So if you're taking 1 versus none or 2 versus none, drugs that have an anti-salivagogue effect, then statistically there was really no effect on any of those salivary parameters, the top 5 being resting and stimulated flow rate, resting and stimulated pH, and buffering capacity, right? If you took 1 or 2, it doesn't matter, no effect on the saliva, if any of those categories. But if you took 3 drugs, across the board, every test, significant effect. That's kind of a big bullet, sort of one of those cutoff point take-homes. I was actually surprised, but it makes sense. But the reasons as to why the cutoff between 2 and 3 and what the pharmacology, this is a real pharmacology question, I think. Why would you go? And the other question somebody told me to pose while I'm up here was, I like when I can come up here and just ask a question instead of answer it. So I'm going to ask it because I don't know the answer. The anti-salivagogue drugs are actually anticholinergic, right? So they're affecting they're atropine-like things. They have an anticholinergic effect. Is that correct? So they should affect the other response. They call it the SLUD response or something. The salivation, lacrimation, et cetera. And so maybe there's less tearing. And it'd be interesting to see if there are other effects besides the salivary effects, which would corroborate these effects. We didn't attempt to study that, but they're anticholinergic drugs, really. This kind of shows the same thing, okay, clustered in a chart. This is from the poster. But if you look at the bar on the right in each of these categories, that when you get to 3 drugs that have an anti-salivagogue effect, you just have this cutoff that all of a sudden you have this effect that you don't have with 1 or 2, okay? We'll have to figure out how to explain that, but it's pretty clear, and it's across the board with all of them. So the results show that the anti-salivagogue medications was associated with lower all of these, but not consistency. So the consistency of the saliva, which was not included here, was not affected. That means viscous versus serous saliva. And that's a whole other interesting one, because if there were an effect related to the viscosity of the saliva, that would be the easiest one to look at in practice, right? You just look and you can quickly determine. You don't have to measure something precisely. I've made the anecdotal observations, something I'd like to study someday. Now that we've been doing this study, I treat a lot of children, and our department sees 1,000 children a year under general anesthesia, mainly for early childhood caries. And we'll be seeing more and more. And my anecdotal observation is that every single child in the OR who has 15 cavities at age 2 has ropey or non-existent saliva. And I think we underestimate. We didn't study that here, of course, but I think there's so much to be learned about. And I don't know if it's cause or effect, right? It could be an effect, not a cause. But from the biofilm, but it's really interesting that we ignore saliva. We have ignored saliva when we're the ones who own saliva. Who owns saliva? Dentistry owns saliva. I see patients in my practice who have special needs. The majority of my patients have special needs. Many of them are chronically disabled, and they have excessive saliva. I mean, the parents complain they're drooling all over the place. Those kids never have cavities, never. The parents want to use Botox injections. That's a new thing to reduce the drooling, because Botox is good for everything, and it does work, but I tell them don't do it. I say saliva is your friend, and that's the quote, saliva is your friend, and it's the best thing. We don't look at it enough. And this study now is going to start corroborating that. This is only one part of it. So these are the drugs that had an effect. You can look at it later, but one of the key things, if you took 3 or more of these, you had a big effect, and that was 8% of this total sample we had. 8% of them were taking 3 or more of these anti-salivagogue drugs. Now, one of the caveats to all this is we didn't control for a lot of things, so we don't know when they started taking the drugs, the exact quantities, so this is not a precise thing. It's kind of like looking at fluoridation. The patient has fluoride from many sources. Did they drink bottled water? They lived in the fluoridated community, but they work over here where it's non-fluoridated, and they took this supplement. It's a complex situation. This is equally, if not more, complex in trying to assess the effect of the medication on the saliva. But you got to start somewhere, but it's important to take note that those things were going on. So I'm going to end with that. I've got about 1.5 minutes, I think, to stay on time and take any questions you may have. Yes? I think it's just on the initial. That was all. That's what the objective was for the initial. That's another, something to be determined later because this is all changing. So we took a point in time, is what we did, and we said at this point in time they're doing these medications, and it's kind of a, I remember when we had these discussions about it, because when you have a large sample, the law of averages should show that for the bulk of people who are on this medication, they were taking it for a period before or a period after, and even though it may change later, it's not going to have an overall effect on the total sample. Does that make sense? So I don't think there is a question later. Yes? How does he make it to 6? I've seen kids, you know, it's amazing. Like you see, people can gum a porterhouse without a denture, you know, right? I've seen people in steakhouses do that. I don't know how they do it, but but they don't do well. You know, it affects them. It affects their self-esteem. It affects their speech. It affects their ability to eat. It's not good. But that kid's going to be, you know, walking around. We'll make a denture of some type for him. That's a pretty dramatic case. But we see a lot of kids that lose teeth before 3 every day. A lot of teeth. It's more of a health issue, by the way, than it is for the teeth. Yeah.
So in this study, what is the thing that you found in relation to the pediatric patients?
Well, so this study,
the medicine or the drugs that they're taking is for adult population, obviously.
Yeah, so I didn't break it down. And first of all, perhaps it was inappropriate for me to show you the kids. I more wanted to show you the reasons why we're looking at risk assessment, because that's a good example. This study, as you know, only looked at children age 9 through 17. That was the category of children because we didn't want to include primary teeth, only permanent teeth in the analysis. And they weren't taking very many medications, so we did not see that effect if you just isolate that population by itself, which is expected because they aren't taking any medications for the most part. You start to see the effect in adults and senior adults, really. Okay. Now, what we didn't study, as I said, is the early childhood. And I've never studied it. There's nothing I looked carefully in the literature. There's nothing there at all, and perhaps that needs to be looked at more carefully. And that's not going to be about medications, though. That's going to be about other things because the kids just don't take that many medications. And the ones that do take a lot of medications are the chronically disabled, and they're drooling because of central nervous system effects. I'm sure their drooling is related to, you know, central nervous control, not about medications, because they're on a lot of medications. Anything else? Yes, please.
Some references quantify a drug's prevalence for side effects like dry mouth, greater than 10%.
Yes.
Or less than 1%. I'm imagining that could be a factor that could skew the 1, 2, or 3 meds thing. If they've got 2 that are greater than 10%, right, it might be a more significant than
You're right.
3.
It's very complicated. You could have one that has dramatic effects, and of course, given that lawyers write those things, like on the TV commercials with all the disclaimers, you know, almost every drug has a salivary effect because 3 patients in the clinical trial experienced it, right? So they say it, but there were 5,000 subjects in the trial, but 3 people experienced it. So every patient, every drug causes chest pain, every drug causes asthma, you know. So sometimes you don't really know how much of an effect there was, although there are clearly some classes of drugs, that, you know, the ones that we showed, that obviously have significant effects. All right, thank you very much.
Thanks, Joe. Thanks, Joe. I didn't introduce you since everybody knows you, but I hope you don't feel bad. Our next presentation is going to be by Dr. John Smith, who's a pharmacologist. John did his master's and PhD in pharmacology and toxicology from Oregon State University, and then he did a postdoc in neuropharmacology from University of Washington. And then after a brief stint in Illinois, Southern Illinois, he came back to Oregon State, and in 1982 joined the faculty at Oregon Health and Science University in the Department of Pharmacology. And he retired a couple of years ago, and so now when he's not playing golf, fishing, or bowling apparently, he is still teaching all the pharmacology courses at Oregon. So our motto is people retire, but no one ever leaves our institution. It's not often when you get to say someone is a true gentleman and a scholar and mean it, but today I can say that. John?
Well, thanks. I've never been introduced as a gentleman and a scholar. That's amazing. Well, it's a pleasure to be here this afternoon. One of the things I've gotten from this, I'm an outsider looking at this, is I'm just amazed at how well you do these clinical studies, and it seemed like with such ease. I've been involved in a couple of clinical studies at OHSU, and they just pulled my hair out. It just drove me crazy. So I'm really amazed at how well you do all this. Yes, I am John Smith, so it wasn't just like to be arranged, a speaker here. John Smith is here. And as Jack said, has been at OHSU for more years than I care to remember. But I just want to point out, if you have any questions about drugs, whether it has to do with the subjects here in this study, or subjects or patients in your practice, or even questions you might have about your drugs your family's taking, whatever, feel free to get in touch with me. My email address is smithjoh@ohsu.edu. Make sure you put that H on the JOH, because there's other John Smiths around, so I've gotten as far as the H. So, but I certainly welcome any questions, and it's probably the easiest way to reach me is through the email. And yes, smithjoh, smithjoh@ohsu.edu. And as Jack says, I am sort of semi-retired, but I pick up all my emails multiple times a day, so I keep in contact with practitioners and students very easily that way. So please, I certainly welcome any of your questions. And my job, I guess, today, is besides answering all of the questions that have already been posed, and will be posed again, I'm sure, if I don't answer them as we go through here, is to just give you a little overview, or a review maybe, of neurophysiology and pharmacology of salivation. And so I want to talk a little bit about what's going on in the salivary glands, and talk a little bit about why some of these medications that were mentioned are doing what they're doing, and maybe address some of the issues as to why it takes more than two to actually see what we're dealing with, which is interesting that it came up, but I think there are some issues as we talk through this. We'll probably see some of the answers, or perhaps hints at some of the answers to some of the questions that have already been posed, so we'll go through that. One of the nice things, and one of the reasons I enjoyed accepting the invitation from Jack, was it gave me an opportunity to talk autonomic pharmacology, and it's not often I get to do that. Occasionally I can, but my training was with my major professor was an autonomic pharmacologist, and all his students had to know autonomic pharmacology, so it's nice to be able to pull it out every once in a while and talk about it, because quite a bit of what we talk about in terms of the neurophysiology and the influence of drugs on salivation have to do with influence on parasympathetic and sympathetic nervous system. And basically, there are a couple of systems are involved, both of them parasympathetic and sympathetic. The parasympathetic nervous system, if you remember your autonomic pharmacology, involves two primary sets of receptors, nicotinic and muscarinic. The nicotinic are primarily central, having to do with the preganglionic innervation, whereas the muscarinic are involved in the relay of messages to the organs and to the periphery. And so those are the ones that are primarily involved in salivation. And when a muscarinic receptor is stimulated, typically we talk about the M3 receptors in salivation. There's a number of subtypes of muscarinic receptors that have been identified. But when those are stimulated, a number of things can happen. Acetylcholine can cause muscle contraction, can increase release of secretion of the glands. Also, muscarinic receptors are involved in the release of nitric oxide. One of the interesting things about the salivary glands, one of the few areas of the body that actually has parasympathetic innervation to the blood vessels. Almost all the other parts of the body, the sympathetic nervous system is the only input to the blood vessels, whereas parasympathetic in a few select areas will have parasympathetic innervation, and salivary glands is one of those. And when muscarinic receptors are stimulated by acetylcholine, this releases nitric oxide from the endothelial cells, in the vessels. And nitric oxide is the vasodilator of the autonomic nervous system. And so that particular, very interesting molecule that is being studied extensively these days in cardiovascular research. But when it is released, it will lead to vasodilation. And of course, what this does is increase blood flow to the gland and increases the volume, so it increases the amount of salivation being given, as well as a stimulation of ion channels and of secretion by the M3 receptor. And one of the questions that was brought up about possible other actions of the anti-sialagogues because they're acting on muscarinic receptors. One of the things that was noticed very early on about the muscarinic receptors of the salivary gland is that they are very sensitive to acetylcholine, that their affinity for acetylcholine is very high compared to muscarinic receptors in other parts of the body. So one of the reasons why you can actually go in and either inhibit salivation or stimulate salivation with muscarinic receptors is that you can do so at very low doses. And to the point where if you're trying to stimulate salivation, you can stimulate salivation without causing a lot of extraneous muscarinic stimulation. So that's one of the advantages, I guess, if you will, if you're trying to manipulate salivation to increase. It's a disadvantage in the sense that a lot of drugs, if they are inhibiting that system, will inhibit that at a much lower concentration as well. And of course, the other system involves the sympathetic nervous system. And the sympathetic nervous system involves adrenergic receptors and stimulation of adrenergic receptors. Generally, these are the beta 2. Remember, all your adrenergic receptors, the beta 1s, the beta 2s, and most of them have subgroups as well. But the beta 2s are involved primarily in increase in protein production, increase in mucin production, and as a result, this leads to the thick saliva. And also adrenergic receptors, the alpha receptors, the alpha 1s and alpha 2s. The alpha 1s, though, are involved in vasoconstriction and blood volume, and as a result, if you stimulate alpha 1s, you get a decrease in the volume. And so we talked about the sympathetic versus the parasympathetic salivation. The ropey, thick, ropey saliva that was mentioned, of course, is typically considered the sympathetic saliva. And of course, and most of you are familiar with that because of the anxious patients that come in have the ropey saliva type of thing. The parasympathetic is what we typically think of in terms of eating, this type of thing. I see it just dramatically in my dog. If I take out yogurt to eat, he comes over immediately and just starts Niagara Falls coming out of his mouth because he knows I let them lick the yogurt cup when I'm done. And so he automatically thinks of that acid and he's thinking of that sweet and it just starts pouring out. So that's the sympathetic or the parasympathetic type of activity. Yes? I'm not sure if that's, I think there is a certain, in terms of quality amount, I think there is a certain advantage to thinking of it that way. All of them, though, they receive, in terms of innervation, will receive this type of innervation. There might be some differences a little bit in terms of the amount of fluid that can be put out by one versus another, but generally speaking, they're all sort of acting the same way, but there can be some differences in terms of the actual amount of protein produced by one versus another. But they're all sort of hooked together. I mean, you can't really separate one from the other when there's stimulation centrally. They're all going to be responding. Now, we talked about drug-induced xerostomia. There's over 400 medications, and I don't know who counts these or who goes through compendium and so okay, there's one listed here. They almost all list these things. But 400 medications, I'm sure that's true. One of the things that when they talk about this is that there's a lot of drugs that will actually enhance salivation. So when they talk about drugs that are modifying or known to cause problems, problems with salivation production, it could be an overabundance of salivation. But in most cases, what we're worried about and what you usually deal with is problems with inhibition of salivation. And one of the reasons why there's so many drugs that are associated with this, and this may go back to they talked about in terms of needing more than two, is the fact that it's a very complicated process, really, when you think about the whole thing. There are two separate neurosecretory pathways involved, parasympathetic and sympathetic. There are numerous, the receptors, specific receptors involved, the muscarinic receptors in terms of the parasympathetic. Also, which you don't hear a lot about, but there are other accessory or adjunct systems involved. For instance, neuropeptide transmitters seem to modify parasympathetic stimulation and salivation. Also, neuropeptides like substance P, VIP, these also seem to modify the response in the parasympathetic nervous system to salivation. So those receptors and those systems are also involved in the whole thing. There's multiple signal translation. That is, the muscarinic receptors, when they are stimulated, they go through a system known as the CIP3 signal transducer, which then activates calcium. And then calcium then activates various channels and increases saliva flow, this type of thing through a system. Whereas the sympathetic nervous system uses cyclic AMP type of system, which then goes into protein kinase and increase in protein synthesis. So there's enzymes and signal systems which, again, are susceptible to drugs. Drugs will act on many of these systems, and so that's why we're seeing a compound action. And also there's ion pumps involved, sodium pumps, water pumps, the aquaporin family of channels. There's sodium channels, potassium channels, bicarbonate channels. There's exchange, which involves active transport types of systems, and drugs can interfere with ion transport. And so basically you've got so many different systems that can be modified. And some of these systems may be only modified a small, only acting on just one small part of that. And so perhaps the reason why you need to see 3 is because of the fact that you've got to go in and interact with a number of these systems to really get significant drop in saliva production. And as I mentioned here before, some systems have more dramatic effect on salivation than others. And so it could be that if you had one of those and a couple of the smaller ones, that'll kick in. The other aspect is that individuals are taking a lot of medications, maybe also taking medications that are physiological antagonists, if you will, to the xerostomic drugs. That is, they actually will enhance salivation. And so the more drugs you throw in there, sure, you're going to get a greater, an opportunity for also have drugs that will block salivation, but you also have drugs that may enhance some of these systems as well. So it becomes more difficult. But it's a complicated system, and that's one of the reasons why so many drugs seem to modify it in some way. Well, we talked about various categories already, and so I just want to briefly go about each one of these categories that have been listed and discuss a little bit as to why they may be involved in that. Of course, the anticholinergic drugs is sort of an umbrella. It can be thrown over a number of different drugs. The anti-sialagogues that are used typically in dentistry are anticholinergic drugs. But again, these are pharmacological antagonists of muscarinic receptors. They sit on the receptor, they prevent acetylcholine from stimulating the receptor, therefore they prevent part of the parasympathetic side. So drugs take, for instance, there are medications used for treating Parkinson's disease that are a part of this. Gastrointestinal disorders, any types of things that lead to diarrhea, often are treated in some way with anticholinergic drugs because the cholinergic nervous system is very important in motility, GI motility. And so in some ways to cut down on diarrhea, all you have to do is block that. Antidepressants, many individuals taking antidepressants these days. Antidepressants basically enhance sympathetic nervous system effects. Their job, if you will, many of these, is to block the reuptake of transmitters both peripherally and centrally, and so they'll block the reuptake of dopamine, for instance. Elavil, its job primarily is thought to block the reuptake of dopamine and norepinephrine, and both of these are sympathomimetic, that is, they're involved in sympathetic nervous system centrally and peripherally, and so they're going to enhance this type of activity, and so if you enhance sympathetic tone, you have a tendency to get the ropey type of saliva. AMAO inhibitors are mainly, again, used for in last-ditch effort in depression, although one MAO inhibitor is used as an anti-Parkinson's drug, and so it is probably the most commonly used. And again, it enhances these things. Even SSRIs, they say that are supposed to be selective serotonin reuptake inhibitors. Well, that sounds good, but they're not that as selective as they'd like to be, and so they're going to block reuptake of norepinephrine and dopamine as well. And so some of these actions will be central. And that's what makes it, again, more confusing, is that, again, since the autonomic nervous system is controlling these through central mechanisms, you start modifying central activity in these systems, and that also can play on salivation. Antihistaminic drugs were on the list, previous list. And a lot of the actions of the antihistamines are due to the antimuscarinic actions. You know, we say antihistamine, it sounds very specific. It's going in and blocking histamine receptors, H1, H2 receptors. And that sounds good, and the industry wants you to make you think that, but in fact, these are very nonspecific agents. And antihistamines are well-known blocking muscarinic receptors. That leads to a lot of their problems, leads to sedation. And this types of thing, constipation that we see from the antihistamine. So certainly they can modify. Anti-neoplastics, cancer treatment, for cancer treatment, these drugs are basically designed to interact with very actively growing, actively processing cells. And you know, the idea is, well, the cancer cells are going to be more active than the normal cells, therefore we're going to kill more cancer cells. Well, that's true, but always when anti-neoplastics, you are going to damage some of the rapidly growing cells, rapidly active cells in the body, and unfortunately the salivary glands is part of that. Antipsychotics. Antipsychotics have antimuscarinic and anti-adrenergic activity. So they'll influence both parasympathetic and the sympathetic nervous system. The antipsychotics basically are thought to act by blocking dopamine receptors. Well, that's fine, but they also will interact with muscarinic receptors or also interact with adrenergic receptors, norepinephrine receptors. And so they're famous for all sorts of side effects, sympathomimetic and cholinergic, anticholinergic side effects. So things like Thorazine, which was the first to come on the market, still probably the most popular today. Mellaril, Haldol, they all belong to different categories of antipsychotic medication, but they all share those common characteristics. Antihypertensives, again, we can as was mentioned, there's all different mechanisms for antihypertensives. So they work through all different categories. And they can work both peripherally and centrally. I think quite a few of the problems with the antihypertensives really are more central than anything else, that they're involving central mechanisms of salivation. But things like the calcium channel blockers. Well, the calcium channel blockers, their job is to block calcium movement. And of course, muscarinic activity is calcium, quite a bit of it is calcium involved in calcium activation. So that can be a problem. Beta blockers are, even the non-specific ones are fairly specific ones are really not non-specific. And of course, beta receptors are involved in the sympathetic side of the whole thing. Diuretics are fairly general in action, but they can lower volume of blood, therefore lower the amount of blood getting to the salivary glands. Diuretics, many of them, their job is to interfere with ion movement. And ion movement is very critical in terms of the renal function, but it's also critical in terms of salivation. So it's not surprising that they're going to perhaps have influence on ion movement in the salivary gland and influence, again, the amount of saliva. And of course, CNS stimulants, their job primarily is activating the sympathetic nervous system. You know, things like the amphetamines, the Ritalin, pseudoephedrine and Sudafed. Their job basically is to increase CNS activity. Certainly we know from the amphetamines, you know, the meth mouth individuals, certainly other factors are involved there besides behavioral, you know, nutritional things and also in terms of blood flow to the teeth. There's also the concept that xerostomia is adding to the meth mouth problems as well. So we know that the sympathetic stimulants certainly can involve these issues. And then miscellaneous, you know, there's others that are just all over, things like the opioids. The opioids, we mentioned the opioids lowering was it lowering the pH or raising the pH? Was it lowering the pH? So becoming more acidic. Well, that's interesting. I'm not sure exactly why that would occur with the opioid. Opioids, of course, are weak bases. How they would lower the pH, I have no idea. I'd have to think about that. That's the first time I've heard that one, so it's interesting. Diazepam, on the other hand, even the sedatives can lead to the problems if they're using for insomnia. Certainly, diazepam is well known to have anti-muscarinic properties, and so it is also an issue. And this was Jack sent me a preview, if you will, of the drugs that were involved, they looked at in the study, and they were broken down by children's and then by women and men, adult men and women, and then an overall top 10. And so this was the top 10 drugs that showed up in the PRECEDENT Co study. I thought was interesting. And in red are the ones that are known to, at least fairly well known, to have salivation effects or xerostomic effects. Of course, aspirin, it's not surprising, aspirin is number one up there. Of course, everybody, at least my age or younger, is taking that 81 milligrams a day, probably. Lisinopril, again, a calcium channel blocker, which is interesting up there. But calcium channel blockers will do the job. The statins, of course, the atorvastatin and simvastatin make up about 8% of the people. Luckily, the statins seem to have little effect on salivation, at least. Unfortunately, people that are taking statins also seem to be taking other medications that do involve salivation, so that's not unlikely. Hydrochlorothiazide as a diuretic, again, its job is to interfere with ion transport, and it's well known to have problems with salivation. Atenolol, which is a beta blocker, as well as metoprolol. And these are supposedly specific beta-1 blockers, and in fact, they do have beta-2 at higher doses, do have beta-2 blocking activity, but probably the actions in this beta blocker category are probably more central than anything else, and so it's difficult to say. Levothyroxine, thyroid replacement. I'm not sure why Synthroid and levothyroxine are listed as separate. Synthroid actually is levothyroxine, but again, this thyroid hormone seems to be pretty good in terms of salivation, not much of a deal. And then Prilosec, again, because of its ability as a inhibitor of proton pumps, inhibitor of pump activity, ion pump activity, can also be expected to have some issues. There's none of these drugs, luckily, are what you consider real major anti-muscarinic drugs, and perhaps that's another reason why you needed more than two to see an effect in the study. Just a few comments on treatment. If you're interested in treating this, like say, sometimes it gets to the point where you really need a treatment. There's been a number of things that have been listed. Salivary stimulants, ascorbic acid, malic acid, these types of things that will stimulate. If there is salivary activity or potential there, it can stimulate activity. Then there's also the artificial salivas that have been advertised and are marketed quite a bit. There's a lot of them. There's various ingredients, carboxymethylcellulose. The parabens are in there. The thing to remember about parabens, a lot of people are allergic to parabens. So those you might be a little leery of. Xylitol, hydroethylcellulose, a number of different products that are out there that people can choose from in terms of artificial salivas that really seem to be most useful, and the studies have looked at them, most useful at night and before the person goes to bed. During the day, they get washed out. They're easier just to sort of drink water than it is to take these. But at night, this seems to be more of an advantage. And then patients can choose from different dispensing options. There's sprays, there's swabs, there's squeeze bottles, and there's all sorts of products. Some are ADA approved, Moisture, Salivart. There's Optimoist, Zerolube. They don't really need ADA approval. In most cases, they're all pretty much the same. The ADA approval, a lot of these companies just prefer not to spend the money to get the ADA approval, but they basically work the same. So that's a potential, treatment. Acupuncture has cropped up as a potential, and in Sweden, there's an interesting study that came out from Sweden that shows some pretty good success with acupuncture. So that's something I think needs to be followed up on, but it'd be interesting to see how that plays out. And then finally, the last ditch, if you really need to use something, if nothing else is working, and you want to intervene, you can use drugs. And the problem with using the drugs are, of course, the potential disease-drug interactions that come from these medications. And the ones on the market, primarily pilocarpine and cevimeline, or Evoax. Pilocarpine, marketed primarily as a sialagogue, is Saligen. And again, I give you the typical 1 tab 3 times a day. But you can use, and generally I would recommend pilocarpine 4% ophthalmic solution. You just take a couple of drops of that, put it in a couple of tablespoons of water, swish and swallow 4 times a day. The main reason it's much less expensive. It's the same product basically, but you're going to pay an arm and a leg for Saligen, whereas this is pretty much dirt cheap, the ophthalmic solution. So go with the cheaper solution. And then again, Evoax is newer on the market. There's some arguments as to maybe it has fewer side effects, but really as far as I can see, there's not much difference. It's seen mainly in treating Sjogren's disease or syndrome, but there is reason, at least there's rationale for using it also in terms of salivation or xerostomia. Just a few points to remember about these medications. If you decide you want to use them, there are contraindications. Asthma, muscarinic stimulations can lead to constriction of bronchial or smooth muscle, which can lead to an asthmatic attack, so definitely it's a contraindication in patients that have a history of asthma. Acute iritis, which is not very common, but that's contraindications you want to avoid. One of the things, of course, that these drugs do, pilocarpine does, is it will constrict the sphincter muscle of the iris, and so it makes a pinpoint pupil. And so when it constricts that, and so that makes that iris move. And if the iris is inflamed, it's very painful to constrict that muscle. So the people will complain. It's not going to cause blindness. It's nothing else, but it is very painful. And believe me, your patient will not appreciate that. So again, that's the reason why it's a contraindication. I put narrow-angle glaucoma down here and on your handout, and I put some question marks on here because it is not a problem. And the reason I put that in is that you do see in some of these drug compendiums, particularly the ones that are directed to dentistry, they say it's a contraindication to give these agents to a person with narrow-angle glaucoma, and which is rather absurd because they treat narrow-angle glaucoma, acute attacks of narrow-angle glaucoma, with pilocarpine. Because basically what it does is constricts that sphincter muscle, it pulls the iris out of the angle of the eye and allows the eye to drain. And so the only thing I can figure out, the reason is that apparently there was a mistake. I noticed this mistake a number of years ago in one of the dental drug compendiums that listed this as a problem, and I talked to the author about that, but apparently they didn't fix it. And what happens is other compendiums just simply borrow from one another compendium, and so it just gets passed on and passed on and passed on. So don't worry about narrow-angle glaucoma. You can use this in narrow-angle glaucoma. And then just some suggestions in your handout. People have talked about these things that seem to help. And drinking a lot of water, of course, during the day is one of the good things to do. Milk with meals helps coat the mouth, keeps them keeps the fluids in. Humidifier at night, bedroom is good. Avoid alcohol, might be one of the toughest ones. Avoid the alcohol. Even in mouthwash, a lot of these mouthwashes have a lot of alcohol in them, so certainly you want to avoid that. Again, restrict caffeine. That's really tough. Restrict alcohol and caffeine. Us addicts would have problems, I guess. But caffeine also, again, has stimulant types of effects and has been known to cause some xerostomia. And again, Vaseline or other products on the lips, it could be artificial salivas, would be a choice at night. And then sleeping on the side, apparently it opens up. You don't have as much drying of the mouth when you sleep on your side. So any questions? Yes?
You addressed the disease contraindications for the cholinergic agonists. What would be the drug contraindications?
Well, drug contraindications, as far as drug-drug interactions, there's not a lot with the drug-drug interactions. There are some issues. There's others that I didn't mention. Because of the fact that the muscarinic receptors are involved in cardiovascular function, especially in heart function, you have to be careful of people with any kind of cardiovascular disease. That could be an issue. And so, in a sense, there is a drug-drug interaction in the sense that it will be, it has a tendency to slow the heart. These medications have a tendency to slow the heart, and as a result can be fighting against other medications the patient is taking. Or it can have additive effects with, say, antihypertensive medications. So, but there's no real contraindications that in terms of the drug-drug types of issues there.
Curious, how does ascorbic acid work, and does smoking potentiate the problems of xerostomia?
How does the ascorbic acid,
Yeah, you
in
mentioned
terms of
stimulating
stimulating
yeah.
salivation? Well, it's not clear as far as why the acidity is doing this. Obviously, there's a link between the central link with acid receptors in the mouth and centrally. And again, the autonomic nervous system is set up to the point where it's going to respond, or it's going to act to the stimulation. And I take my example of my dog. I mean, the acidity of the yogurt will stimulate the salivation. Just the thought of that is going to cause something. So I think those types of things, the acidity is associated with this reflex link, autonomic reflex link centrally. So I guess that's the way I would try to explain that.
Question over here.
Yeah.
What is Ford Extreme Gum?
Yeah. Ford Extreme Gum is gum that has xylitol in it. It's an example of a xylitol-containing gum. That's all. I don't have any stock in Florida, so believe me, that's just as an example of one thing.
So my question is, the major problem we face in regard to xerostomia is in elderly people is this: if we use the salivary substitutes, it doesn't last long.
Yeah.
And that is the major issue that I have when I treat, and when we are getting the issues with the xerostomia, that is caries, then that is one of the most difficult thing in dentistry to address. Mm-hmm. And I'm looking all around to find a product where at least it has 6 hours of effect at night, and that will have a dramatic effect in taking care of people who have that. So the pilocarpine, how long does it last, in the sense that how long will it work?
I mean
The effect of the drug.
Saligen, that type? Well, you would expect at least 6 to 8 hours with a dose of it. So theoretically, if they took it just at night or prior to night, you should get some salivation, through that. Now, again, it's something that it's a trial and error type of an issue, because you don't want a lot of salivation trying to sleep. So, if you're sleeping on your side, this may not be such a bad deal. But again, it can be a trial and error type of thing, and that would really be the best way to approach it. To run it all through during the day, I think is you're asking for a lot of issues in there. But at night, that could be one way to approach it, and you should be able to carry through most of the night. I don't know how long people plan to sleep, but 6 hours is a good day. 8 hours for me now, but when I was teaching, 6 hours looked pretty good. All right.
For those of us at OHSU, do you have a word of the day?
He's referring to my word of the day. I used to always have a word of the day, or a cartoon of the day. And no, I can't think of the word today. You got me flat. I have plenty of them, though.
I have a question, and it's kind of to Dr. Berg as well as to Dr. Smith. It wasn't clear, but can I make the extrapolation that from study 2, with the 3 medications and the significant xerostomia, the reason is because it's probably affecting both the parasympathetic and the sympathetic systems, and that's where you see the increased hypofunction?
Well, I guess it doesn't necessarily mean that. It could have drugs that are acting in multiple areas within a system. It could be acting on the sympathetic nervous system, and then maybe drugs acting on ion exchange or ion channels. Or it could be a drug that's acting on the sympathetic and the parasympathetic, but not necessarily. Just any combination of those, whereas one action alone, again, the body is as we know, is very resilient, and especially when you're talking about autonomic nervous system. The body will always fight against any kind of a change. And so if one drug is causing a change in salivation, there's going to be mechanisms that are initiated that are going to try to fight against that change. And so, again, that's another reason why you might need more than one drug to get an overall effect, is that maybe you're going to need to take a second drug that's actually going to be inhibiting this reflex in some way, so that it's cutting back on. And the same thing with antihypertensives. When you lower blood pressure with a diuretic, one of the reasons why on this list we have the beta blockers and the diuretics, you lower blood pressure in a diuretic, and as the blood pressure go down, the baroreceptors say, hey, we got to do something. What can we do? We can increase heart rate. And so the increased heart rate to fight this drop, so you throw in a beta blocker to fight that. So I'm thinking more that it's sort of a combination where you're getting the right, sort of the perfect storm, if you can, of drugs that are going to lead to this issue.
Okay, I think one more, and then we'll break.
So, so far we're talking about medications that cause xerostomia and have to do with salivary flow. But are there any, at this point, medications that we know of that will affect the constituents of saliva? Because obviously we're talking about something in saliva that is preventing dental decay. And these drugs are preventing saliva from getting to the tooth surface, but do we know of anything that's affecting what's in the saliva itself at this point?
Well, I don't know of any, there are certainly drugs that will affect components by increasing or decreasing. Whether it's putting new components in is not likely. Certainly protein production, anything that's involved with inhibiting sympathetic input's going to involve some kind of component to that. I'm not aware of any drugs that are actually taking out as a particular component of the saliva. Of course, drugs, another thing too, I don't know if this probably wasn't done, is in terms of analyzing the drug in the saliva itself. Of course, the drug is going to be put out with saliva onto the tooth surface and onto that. And there certainly, to me, that would be more likely to have some issues there than the components themselves. But again, that's something that I'm really not an expert at, and I'm not aware that anybody's looked extensively at that as well. But I don't know, there could be, but you'd think in some way, based upon what we've seen here, that there might in fact be some type of changing in the component. And I'm sure that they've looked at, if you look at change in components in different individuals, the link between the drugs and those components, I'm not aware of.
Okay, thanks, John.
Thank you, Jeff.